you all. We're going to move now into a roundtable discussion that will build off of Tom Frieden's excellent presentation. I'd like to invite my fellow panelists, Deborah Work-Zoide, Rob Bryman, and Dana Hovig, to come up and join us up here and take a seat. And we're going to have a lively interactive roundtable discussion, and we're going to, I promise you in the audience, we're going to move rapidly to bring you in to this conversation. We have asked the three of them, Deborah Dana, Rob, and they'll go in that order, to open up with several minutes of comments that play off of what we've heard from the very comprehensive scene setter that Tom has provided. Deborah Work is known to many of you here. She is a PhD immunologist. She began her career in Ethiopia. She began her career in the national laboratories. She migrated from there to begin working across East and Southern Africa in AIDS programming with family health. She graduated from that into the World Bank, where she has been a senior career health expert, directed the AIDS program there. She's there now as a senior advisor on the Millennium Development Goals, among other things. She took a segment of her career out in recent years to serve as the deputy director and chief operating officer at the Global Fund in Geneva during a particularly critical period in that organization when it went through a massive managerial and funding model rehaul, and she was at the center of all of that. Dana Hovig comes to us today from Seattle, from the Bill and Melinda Gates Foundation. He is the director of integrated delivery. This is a very exciting, and as he will explain, a very exciting and important new dimension in the health systems work that the foundation is carrying forward. It's a big change. He came recently to the Gates Foundation after a very distinguished career, 7-8 years directing Marie Stopes International, there as the CEO, overseeing programs in family health, in HIV/AIDS, in reproductive health in over 40 countries. Prior to that was with Population Services International, another terrific implementing non-governmental body. He spent 10 years in Pakistan, and prior to that in Mali and other parts of West Africa. Came to this work as an economist and as a political economist, very unusual background. Rob Bryman is now back here at Emory. He is an MD and an infectious disease expert. He is the director of the Global Health Institute at Emory. He spent 9 years in Kenya. That's where we first met, directing the CDC programs there. Highly innovative. You've seen him in one or another of our videos around the work that was undertaken, bringing new technology and data into Kibera. CDC doing some very innovative work. He spent, prior to that, 4 years in Bangladesh. He was instrumental during the SARS outbreak in China in the early part of the naught decade. Experience directly relevant today as we struggle with the MERS. So we've asked the three of them to kick off with some comments on the particular angles that they see in this big question around what's the unfinished business, what are the outstanding challenges as we look forward in the next 10 years, steer us towards what the top line priorities should be, and how do we have to begin to change practices and thinking. And when I say we, I mean a broad range of partner governments, of foundations, of implementing non-governmental bodies, faith-based bodies, and donors. So it's a broad spectrum of interests, but we have this opportunity right now to be very self-critical and to begin this. And we'll come back and get Tom to join us in that conversation after we've heard from from Deborah Work, Dana, and Rob, and then we'll quickly turn to you and offer the opportunity for all of you to come to the microphones that have been set up here, offer your quick comments and questions. So thank you so much. Deborah, why don't you kick off? Why don't you speak from there?
Yes.
If we can speak from the chairs, that'd be great. Thank you.
Thank you. Good morning. Let me start by thanking Steve, Helene, and Wayne for inviting me to this. I'm really grateful, and it gives me an opportunity to speak after a great man. If you're lucky, you need to talk after Tom Friedman, because he would have given you the statistics, the landscape, and where Africa stands now, which is what he did a few minutes ago. I would start with a disclaimer, and I'm going to talk to you as an African. The tremendous amount of support, whether it's in resources, knowledge, and personal sacrifice by many in this room, many who are not with us, is something which I, as an African, and all Africans are grateful for and indebted to. The US, in my own field, is the largest contributor of funds to PEPFAR and to the Global Fund, which is taking care of most of the malaria, HIV/AIDS, and tuberculosis problems, especially in sub-Saharan Africa. So that's where I'm coming from. As I work on MDGs now, I also see a huge unfinished agenda. We have made progress, and Tom, I'm not a pessimist, but there is a lot to be done. So I'm going to talk to you a little bit about 3 MDGs. MDG 4, which is about child health, MDG 5, maternal health, and MDG 7, which is very important, access to water and sanitation. When you look at all this, you see a huge discrepancy in what's happening in sub-Saharan Africa, and there is no other continent like it. We have data from about 50 of the 54 African countries, and you did mention the 3 impediments, which is infrastructure, conflict, and pessimism. When I was a student and when I started my career, I have been hearing there is no data. There is no data in sub-Saharan Africa. 2014, we are saying there is no data. There is something wrong with that picture, which I'll come to. So if you take about these 50 countries where we have data, 32 of them are not going to meet any of these 3 MDGs. MDG 4, MDG 5, MDG 7. 19 of the 50 will reach one of these. And 11 of the 50 would reach 2. So that's what it looks like. There are only 4 countries that are going to reach MDG 5. And we have a funny way of describing it, which says country X will reach MDG 5, or country X is expected to reach MDG 5 by 2050. Anyway, 4. 12 of them would reach MDG 4. 18 countries would reach MDG 7, which is access to water, but only 3 would reach the sanitation goal. So that's what you have. And for me, that's the unfinished agenda. And over 25 million live with HIV. We have made tremendous progress. I was at the center of it when it was a joke to assume that we would reach 3 million people by 2015. We have over 10 million people on treatment now. Still, it's a huge agenda. So this is what I consider as the unfinished agenda for sub-Saharan Africa. Nothing like it. Most other continents have made tremendous progress. So the question for me is, what are we going to do in the remaining, I think, about 200 days? Are any of these countries going to do some miraculous thing which they haven't done in the last couple of years? The other issue which should concern us is the countries that have made immense progress, how do we sustain it? For those of you who follow the MDG debates, if you have a scale of 100, about 40% is about the current MDGs. The agenda has already shifted, the post-2015 MDGs. What is going to happen? It's excellent to have goals. By the way, I love vertical programs for a reason. It is not the vertical programs that are a problem. In the HIV/AIDS era, we have built excellent programs, but we failed to learn lessons and to use the infrastructure that has been developed for HIV/AIDS for other diseases. That's the problem. It is not the verticality. So if you look at all of this, and if the post-2015 agenda, the overarching target is universal access to health, then the issue is, what do we do? How is Africa going to make it to this? What are the lessons from the current MDGs? And what will make the post-2015 agenda work? If we have all these gaps, please do not misunderstand me. Maternal mortality, if you compare it from 1990 to 2014, there is a 45% increase, which is not enough. So what is the lesson from the current MDGs which will help us make 2015 a success? The Lancet has a beautiful article which was mainly funded by the Bill and Melinda Gates Foundation, and they have 4 important criteria for the countries who have made it. The first one is leadership. Again, we have seen it in the AIDS epidemic. The countries who woke up to what AIDS is all about and what they need to do are the countries whose leaders understood what it was and allowed the technicians and the NGOs and the activists to do their work. That's an excellent example of a vertical program which you can turn into what do we do as we go into the post-2015 agenda. There are leaders like Museveni. No matter what we think about Uganda now, Uganda was a leader, and its leader was a leader when we started HIV/AIDS in Africa. President Moi. These are the leaders who of course, we had an example which Helene would remember from South Africa as well. But the moment the leaders turn around and accept an agenda, they can make it. The second one is evidence. You have said it. If we don't have data, we don't know where we are coming from and where we are going. The third one is strategy, long and short-term strategy. This is what should worry all of us. If we do not maintain the success in the countries that are on an upward trajectory of the current MDGs, how are we going to be able to fulfill the post-2015 agenda? And the fourth one is an adoption of change for sustainable programs. I think these are excellent examples that have been given by this Lancet article, which summarizes what we have done in the past few years. For me, there is one thing which is important, which is we need a mindset change. If all this effort, the resources, the manpower, the infrastructure, etc., has changed what we do in Africa, but not enough, then we should ask ourselves, have we been doing the right things? One of the things which I think is important is we need to stop talking about Africa and replace it with, we need to talk to Africa. We may make a difference there. And we need to stop deciding for Africa. What we need to do is let Africans decide and support that decision. It's okay if we make mistakes. It's much easier to honor your own mistake than to blame it on somebody else. If I was with another audience in parts of sub-Saharan Africa, I always get irritated when every problem is blamed on colonialism. That was a long time ago. So we need a mindset change about Africa. We need to talk to Africans. We shouldn't talk about them. And we need to make them responsible by letting them decide and supporting that decision. Maybe we'll get somewhere. Thank you, Steve.
Thank you very much, Deborah. Next, we'd like to hear a few words from Dana Hovig. Thank you, Dana.
Great, thanks, Stephen, and thanks for this opportunity to speak to you on behalf of the Bill and Melinda Gates Foundation. Stephen's asked me to talk for just a minute or two about the foundation, and then maybe comment on some of the other remarks you've just heard. We're a new foundation. We're learning and growing and changing. I think it surprises people to hear that we're only about 15 or 16 years old, and are actually quite self-critical and reflective in trying to change and adapt to new opportunities, but also to lessons learned and mistakes made. We aspire to do something that we call catalytic philanthropy, which effectively tries to fill the middle space between the public sector and the private sector. We see the private sector as huge innovators and efficient and effective in their own way, willing to take big risks. We see the public sector as having huge resources and ambitious social aims, but risk averse. And so we try to de-risk investments on behalf of the public sector and the private sector so that they can partner better together and overcome the issues that we all care about around the world, and particularly in sub-Saharan Africa. The foundation is organized historically around what we call the verticals, around the family planning and maternal and neonatal health and HIV/AIDS and tuberculosis. And those still remain our center of gravity in health, but also in the rest of what we do. We pay out about $4 billion a year in our foundation. About half of that is from Bill and Melinda, and half of that is from Warren Buffett, in fact. And about $2.5 billion of that is for health, and particularly global health, with the remainder invested in U.S. education, in global agriculture, in financial services for the poor, and social inclusion. So my team is pretty new, and I think this is a reflection of how the foundation is evolving. My team, the delivery team, or integrated delivery team, is really meant to help the verticals, the family planning team, and the HIV/AIDS team, to deliver better and deliver more of the life-saving tools and technologies that they develop, but also to look for opportunities for integration, as Deborah Works and Tom mentioned, to build health systems on the back of HIV/AIDS investments or maternal and neonatal health investments. Like you've heard from Tom and others, we at the foundation think this is a time of enormous opportunity. And particularly now is a moment that we need to seize. We also in the foundation feel a sense of urgency that now is the time to act. I think this is why you may have heard about Bill and Melinda and Warren also trying to get billionaires to pledge half or more of their wealth to spend during their lifetimes. And they've now got 130 billionaires who've pledged to spend their wealth, or more than half of their wealth during their lifetime. So this is a marker of the sense of urgency, not urgency for results today. We think at the foundation that it's a long game that we need to play in order to overcome some of these issues, but a sense of urgency to actually make bets now, to act now, knowing that some of those bets may come good and some of those bets may not come good. Deborah Work mentioned the Commission for Investing in Health that we co-funded with the Norwegian government and the British government, and that was chaired by Larry Summers and Dean Jamieson, and I would urge you to look at that. It's in the Lancet December 2013 series, and what they concluded we think is quite powerful, which is that in the next 20 years we have a real opportunity to eliminate or largely eliminate global health inequity around the world, including in much of sub-Saharan Africa. There could be a grand convergence around, for example, under 5 mortality. The sub-Saharan Africa and other poor countries around the world can, in fact, have under 5 mortality at the levels that we've seen in the UK and in Europe and in the US. If we act now and if we do the right things, that the return on investing in health is huge. For every $1 invested in global health, you can get between $9 and $20 of economic return from that investment. So we think now is the time to act, and we think that the Commission for Investing on Health is, and some of our own deliberations have caused us to rethink a bit of how we invest and what we might do. First of all, we know and we think that there's about $120 billion spent on global assistance for health from donors and international agencies, $120 billion. We think that we need to get ready for a world where that's largely going to plateau or move up only incrementally. So what does that mean for us? It means that we need to invest in the things that work and stop investing in things that don't work based on evidence. The Commission for Investing in Health talks about family planning and investing in immunization, in infectious diseases, and building primary care systems that can deliver the tools and technologies and drugs and diagnostics and vaccines that we know that work. At the Gates Foundation, we also talk about investing increasingly in what we call public goods, either in the country or at the global level. Tom mentioned investing in mini CDCs around the world. We think that these are institutions that can really matter to the futures of countries in sub-Saharan Africa. We historically have invested quite a bit in upstream R&D and invest now about $600 to $700 million a year in R&D. We do that because we see a real market failure in this R&D space. There's only about $3 billion a year spent on R&D for the diseases that afflict poor countries. Contrast that with the $50 billion or so which are invested in the diseases that afflict rich countries. So there's a real market failure in this, and we think that needs to double from around $3 billion a year of investment in R&D to about $6 billion a year. We know that just developing these tools and technologies doesn't do any good and doesn't save a single life. We recognize, and this is one of the things that my team's working on, that health systems need to be much more nimble and adopt innovations and best practice much faster. Right now, the whole innovation introduction space is broken. You develop a new tool or technology, or there's an existing tool or technology which can save a lot of lives, and you have to introduce it one country at a time, one provider at a time, and one tool at a time. And that whole space we think is broken, and we think that there's a better world that we can contribute to help creating. And finally, my team is starting to think about how we might invest in building primary care systems. We think that those will be the backbone for the innovation introduction and for better health for sub-Saharan Africa and elsewhere. If there's one takeaway, however, from what I wanted to talk about, it's that domestic financing and country financing in sub-Saharan Africa and elsewhere is actually going to be the key to this grand convergence. Right now, countries around the world, developing countries around the world, spend about 2% of their GDP on health. And we think, and the Commission for Investing on Health estimated that they need to spend about 3% of their GDP, of their growing GDP on health. There's an opportunity to do so. But what does this mean for us as global actors and players? It means what the Senator talked about earlier. It means that it's no longer about the blunt instrument of our money making a difference. It's about soft power of influencing the decisions that rightly countries in sub-Saharan Africa and ministries of health need to make. It means influencing them to be stewards of their entire health system, the public sector, the private sector, NGO and faith-based service delivery providers, rather than just taking a public sector-centric view of the world. It means that influencing the decisions now, because we know that decisions that they take now around their health system really matter for 20 or 30 or 40 years from now. We know from our own experience of the health system in the US that health systems are sticky, that once you make investments and once there are vested interests in a certain type of system, that it's really hard to change it, it's really hard to evolve that. And so the decisions that these countries make now will really matter for 20 and 30 and 40 years ago. I'll close by saying that we believe that now is a moment of opportunity, and we need to seize that opportunity, not just for the lives that one can save today, but also to build up the resilience to take on tomorrow's shocks and tomorrow's challenges. And Rob's going to talk to you about some of those challenges of tomorrow. If we don't act today, then the healthcare systems and the people won't have the resilience, in fact, to overcome what's, I think, coming soon. Thank you.
Thank you, Dana. Thank you, Rob Bryman.
Thank you. Thank you, Steve. I've been sitting here thinking about how to follow such wisdom and depth from Tom and Deborah Work and Dana, and I'm not sure. But I do have a few quotes to respond to some of Tom's quotes. Mahatma Gandhi also said, be the change you want to see in the world. And I think that much of what we will be doing over the next 20 or so years is not only the big corporations and philanthropists, but what we individually will be doing and how we'll connect to each other. And Mother Teresa also said, not all of us can do great things, but we can do small things with great love. And if she was an epidemiologist, she would have said with impact, with great impact too, I think. And I think that one of the issues, one of the problems, or I guess I'd say one of the exciting things about being in global health is that it's a moving target. You know, what we were talking about 10 years ago as being things that were very important to do, you can see a lot of these things are being addressed and new things are arising that are important, like, as Tom mentioned, non-communicable diseases. I'm glad to hear that several of the speakers referred to inequities as sort of part and parcel, fundamental as to what needs to be addressed. And inequities, in a way, define really what global health is all about. And often, when I think of disparities or inequities, I think of this phenomenon that's going on now in the 21st century, which is urbanization, which is occurring at a rate in Africa 5 to 7% a year. And when people come in to urban centers, they wind up in urban slums. Almost everybody does, because the cities can't keep up with the infrastructural needs and challenges. And as a result, diseases that were important in the 19th century have reemerged and are important now in the 21st century in these places. So for instance, with typhoid fever, a disease we shouldn't even be talking about. If we had a couple of cases of typhoid fever in Atlanta, that would probably be front page news. But in Kibera, by the age of 10, a child has a 1 in 5 chance of experiencing typhoid fever. Shigella, cholera, all of these are markers of either failed or not existent infrastructure. So, so there are many levels to consider with infrastructure. I totally agree that the public health infrastructure has a ways to go, but has really made huge progress in the last decade or so. The field epidemiology training program that Tom mentioned, I had the pleasure of being involved with starting it, the version in Kenya. And by the time I left, so it started in 2004 and I left in 2013, many of the mid and senior level leaders in the Ministry of Health were graduates of that program and really had US style capacity to gather, examine evidence, and deliver interventions and evaluate the impact of those interventions. Really a fantastic change, and this is happening all over Africa. But there are these other infrastructural changes that are occurring too that we'll have to figure out how to address. Along with issues of inequity, are side-by-side issues of social justice. An author named Brian Stevenson said, the opposite of poverty is not wealth. In too many places, the opposite of poverty is justice. And so I do think that in a lot of what we think about as we approach Africa in the 21st century, including issues of climate change and climate change itself and its extreme events, drought and torrential rains and so forth, will primarily or in a very big way affect urban areas. We saw the impact of Typhoon Haiyan on urban areas in the Philippines, which because of dense population, poor emergency services, the impacts were huge. And so when you think of the issues of the 21st century, whether it be extreme weather events and climate change, land use change, which is caused by urbanization and results in all sorts of issues related to agriculture and nutrition, as well as emerging infection risks, and water scarcities and safety, which are also rolled in. and the demographic and lifestyle shifts. When people move into these urban areas, their lifestyle change. They're not as active. They're eating different types of foods that are not necessarily the healthy foods. It's a more stressful existence. And these diseases that we've heard about, like diabetes and hypertension, cardiovascular disease, are really emerging in a very big way. So I do think that there are some paradigm shifts that are going to be required. It is wonderful to see. I mean, the progress, as has been said, has been huge over the last decade. But as I think others have said as well, that clearly we can't rest on our laurels. There's unfinished agendas, so these things that have been mentioned, and there will be new agendas that will be rising. And I guess the last thing to leave you all with and to think about is that it's not just a public health problem. In order to deal with these things that I'm talking about, there'll need to be involvement of business, of legal, of political, of historians and anthropologists, religion, and I think all together begin to address some of these challenges of the 21st century.
Thank you, Rob. Just listening to the four presenters, one thing that jumps out is there's a certain amount of realism and caution that comes through these comments around the decade of remarkable progress and then looking forward in the next decade. And what I'm hearing is we better be careful that there is a risk here of a stall. There's not going to be major new donor dollars coming forward in this next period. There's been resilience at staying where we are. There's been remarkable resilience on both the USG, the multilateral dollars, other donor dollars. But there's a realism that comes through. And the Lancet series is trying to create a vision of convergence and of transformation that happens, but it's predicated on overcoming a couple of major factors that have come up in this discussion. One is simply the availability of resources within governments that are strapped and which have many different competing objectives and priorities, and which have grown accustomed to a very large segment of the health agenda being covered from outside sources. So there's the dependency and entitlement, and there's the internal competition against many different priorities, and there is the scarcity factor in terms of resources. So that is one thing. Security. We've heard a lot about security, and that is for many countries a serious concern. One thing we haven't heard much about here is really the leadership deficit. When we talk about where the leadership is going to be coming from at the head of state level, at the opposition leadership, at the finance ministerial level, we have to ask ourselves, where is that forward-leaning leadership going to come from that is going to say, despite these constraints, health can be moved forward in the way that this Lancet Commission says it has to rest in the hands of African governments. This has implications, it seems to me, for U.S. policy. It has very serious implications. It has very serious implications for corporate policy and for engagement by non-governmental groups. It suggests that in the next decade, U.S. diplomatic and political engagement in Africa is going to need to center around these issues, around how to be most facilitative and supportive at trying to raise the profile and the will, the political will among leadership to take on this agenda that we've been told has to be carried by them. We've seen Secretary Kerry's speech recently in Addis Ababa. We've seen the global security agenda rolled out in February with Tom Frieden's leadership as an important new way of engaging with political leadership in Africa and elsewhere. We're going to have the Africa Summit August 4th, 5th, and 6th in Washington, D.C., which will give a very, very emphatic focus upon trade and investment, trying to interest the American corporate sector to talk more and engage more with leadership from Africa. Health is part of that agenda, too. So our diplomacy is changing, but behind it all is the kind of cautious warnings that are contained in many of what you are all saying, that The next decade is going to be different from the not decade. The not decade where we went from 7 billion going into global health to 30 billion in rocket speed, and now we're plateaued. So I want to come back to Tom and ask Tom for his reflections on that big issue, and I want to invite our audience members, and we'll have a little bit of interaction from some of our other speakers here, and then I want to invite those of you who wish to offer comments and interventions. There's a microphone here and there's a microphone there. We have until 11. We'll have one round of discussion here, and then we'll turn to you. Tom.
I'd like to start with just picking up on something Rob talked about, the field epidemiology training program in Kenya. And the difference it's made there is enormous. You have now Kenyans who are fully able to look at the data, generate data, make decisions on data, but they also have exported in a very positive way one of their graduates to start the same type of program in Nigeria. The Nigerian program is doing wonderfully with that individual's leadership, and now is the largest field epidemiology training outside of CDC US. And their graduates, their trainees, and their related organizations are undertaking, frankly, the most successful program I've seen in Nigeria, a program where they've been deployed to the most problematic LGAs, local government authorities like counties, to work on immunization. And they've done that in a very structured way. And within a year, you're seeing 20, 30% increases in immunization coverage in the hardest to work on areas. So I think we should think about the amazing return on investment, and Dana talked about the tremendous return on investment of developing high quality staff who are able to track data, set policy, evaluate programs, make progress. I want to raise the issue that Dana raised about public goods, because for me, this is frankly the hardest area to think through and to figure out a way forward on. How do you get governments and donors, frankly, to emphasize and invest in and fully support things which are wonderful, but the benefits are widely distributed? And Dana, with his political science background and economics background, may be able to help us on this. We have a tragedy of the commons within both some donor entities and many governments. There's an understandable push to do that which is most urgent, that which might have the most political heft behind it. So you might, in country X, have immense pressure to ensure that the university hospital that cares for the people in the capital city is very well funded, doesn't have waiting lists, has good doctors there. But you are not likely to have anything like that kind of pressure to establish a surveillance system so that people will be tracked and health trends tracked and primary care focused, so people don't actually need to come into that tertiary care facility in the capital city. And the question I would throw out really is, how can we increase investment in public goods like public health institutions, like epidemiologic training, like surveillance, that don't have either the employment political economy behind them in low and middle income countries, or the politics of some of the entities that would push for other priorities within or outside the health sector.
Dana, you want to jump?
Yeah, thank you, Tom. I have a couple of reflections on that. First of all, I think that we in the global health community probably need a greater discipline about how we think of public goods versus private goods. And a lot of health is in fact public health and is a public good. A lot of health is also actually a very private good. And being disciplined about when you make investments in public goods, then the results that you're trying to achieve are a little more opaque, but need to be measured in their own way. When you make investments in the delivery of health for individuals or communities, I think that this tenacious focus on the MDGs and outcomes and accountability has been right. The problem is that we have a continuum of public goods to private goods, and we've sort of typically act in the mushy middle, where there's very little accountability, very little results, and people hide behind the public good language. And so I just think a greater discipline about investments in health for what? For a specific result, for a public good. I think we need to invest much, much more in public goods and then call it that. It's a public good, and we need to measure what public goods do. And then the rest of it, we just need to be much more tenacious about results-based financing, about money following the patient, so that people can make decisions for themselves about where they seek health care, and then the money follows those decisions rather than thinking on behalf of people.
And how do you think when you look ahead at, say, a priority country like Nigeria, where from a USG standpoint, from a Global Fund standpoint, from the Bill and Melinda Gates standpoint, from the World Bank, it matters so significantly and requires assiduous engagement. What is the approach to motivate, to attempt to motivate? How do you go about moving ahead? I mean, Africa is pretty chunky in a way. When you look at DRC, Ethiopia, Nigeria, you've got a large portion of unmet need and population, and the whole question of engagement and motivating countries to do more, to make these a public good that they invest in. How do you think about that?
We're considering what we might do further in Nigeria, and I was there a couple months ago also, and we saw that the fundamentals of the health system are broken. So we know from a World Bank survey that about people see their public health clinic on average. There's 1.5 people per provider per day who see a public health clinic. In other words, a clinic with 5 or 6 people sees maybe 10 clients a day at most. And so the system is broken, and people don't trust it. Supply chains are broken, and so they don't go and see it. And the reason it's broken, we think, is because it's fragmented. Because the people report into one ministry, and the money flows from a different ministry. And supply chains have 6 or 7 different supply chains providing drugs and vaccines to the same primary healthcare outlet. So the system is fragmented. And so what we're thinking about is I think the issue that you brought up earlier, Stephen. It's about leadership. It's about management. It's about execution. And we want to intervene in Nigeria such to bring the best-in-class business practices and execution practices to the health ministry, and particularly at the state level, so that they can learn and not from international agencies necessarily, but from the business coach that Coca-Cola or UPS uses in Nigeria. Those are the people that we think can actually tutor and help the Nigerian government, other Nigerians helping Nigerians to learn how to execute and how to bring this fragmented system together so that you can hold health ministry leadership accountable. Right now you can't hold anybody accountable because it's just too fragmented and nobody really has authority over the system.
Deborah, do you have thoughts on the whole question of African leadership, and where is it? And where do you look to see the greatest potential opportunity?
A couple of things. If you go to any country and you say, whose program is this? They will not say to you it's a Nigerian program. They say, oh, it's a PEPFAR program. It's a Global Fund program. It's a World Bank program. For me, that is of primary concern. Ownership. If they look at it, that this is their program and invest their own resources in it. There are many, Africa is a huge continent which contains the poorest countries in the world, and there are countries who can fund their own system. They are not. So that's the first thing. It is political commitment is not only leaders allowing people to do what they have to do to combat a problem, it's putting their own money. Let me give you an analogy. In one country, the money which the Global Fund was donating to the country for AIDS, tuberculosis, and malaria was bigger than the health budget. And tremendous results. The money goes directly to the Ministry of Health or to the recipient NGOs, both international and national, who execute it. I had a discussion with the Minister of Finance. He had no idea how much money was coming to his country. That's a fundamental problem because it's ministers of finance and ministers of plan who allocate resources to programs. So while money which is coming from outside is important and has made a lot of difference, it's critical to make sure that the country puts its own resources and says, this is my program, which I'm doing with the support of so-and-so. That's one. The second one is the CDC has done a fantastic job in every single country in Africa that I know of. Surveillance system, epidemiology. The retention of the staff that you train in country leaves a lot to be desired. That has everything to do from the government not being able to give them the appropriate salary to trying to live a better life just like everybody else and fleeing. I say it as an example, this has changed a long time ago. I used to run the National HIV/AIDS program in Ethiopia. After I joined the World Bank, 10 years later, I went in and I said, where is so-and-so? Oh, he is with the CDC program. The CDC Ethiopia had a fantastic HIV/AIDS program. The people in the ministry where we had the National AIDS program have migrated. Why? Because the ministry was not giving them what they required to do their job. So these are the things which need to change. And it's not an overnight thing. It is not one thing. It is a combination of everybody working towards this. I think that's what
This really is a key issue, and it's related to the public good. How do you get the public sector to invest adequately in the things that it needs to deliver value? In many countries, that will be better, but fewer. Fewer workers, but a higher pay scale for those workers. That's very difficult politically to make happen. So this is a core challenge for not just Africa, but countries all over the world. The public sector will do less and less delivery of direct healthcare services in many parts of the world. Not everywhere, but in many parts of the world. A greater and greater proportion will be done by non-governmental and private sectors. But the government, the public sector, will always be responsible for things like setting standards, ensuring registration, monitoring quality, and filling gaps. But to do that, it needs a whole different set of skills, and making sure the public sector keeps up with its staffing, with its training, with its infrastructure, its technology. That's a cardinal challenge that isn't sexy for either politicians within the government or for donors. And that is one of our main challenges related to this delivery of public goods issue. That's why we've been focusing on the global health security approach, because this is an area that every country understands. If you're the leader of a country and you can't find and stop an outbreak, you're in big trouble politically. It doesn't matter if you're democratically elected or otherwise, you're going to lose the trust of your people. So there's also an understanding that it's devastating from an economic standpoint. SARS cost the world $30 billion in 3 months. Already we're seeing huge travel implications from MERS coronavirus. Avian influenza has cost billions of dollars to many of the agricultural industries in Asia. So the economic costs are enormous, and the amount of investment that's needed to strengthen the public health system is a tiny, tiny fraction of that. And yet the political economy to allow that kind of investment is very challenging.
We're going to move to our audience now. I'd ask you to please come to the microphone and queue up. I'm going to ask, Rob has an intervention here, but please come and we'll move to you momentarily. Please identify yourself. Please be very succinct, and we'll bundle together 3 or 4 comments and questions at a time so we can get a number of issues out and we can come back to our speakers. Rob?
Well, just briefly, because I see people are standing up, I think that this retention issue is really a critical problem, and it gets back to actually recognizing the return on investment. I have to say that when we started this program in Kenya, initially there wasn't that much excitement about the FETP, this training program. But in 2006, there was a Rift Valley fever outbreak that was huge. It happened to occur. It started in the Northeast right before Christmas. And the FELTP, just like EIS officers in the United States, responded in full force. So that a few weeks later, the director of medical services in Kenya said, I don't know where we'd be without the FELTPs and the graduates. We already had a few graduates at that point. And ultimately, they took over the program. So initially, it was sort of CDC guiding a program director and so forth. Now it's totally independently operated, and CDC sits as sort of a technical advisor for some aspects. But the issue of salary remains, and it has not been resolved. Despite that fact, because I think people find this to be personally fulfilling, maybe not financially fulfilling, they still have managed to have almost an 80% retention in that program. But I can't say that will go on forever without some bigger solution along the lines of what you talked about.
Ginger?
Good morning. Ginger Floyd, Morehouse School of Medicine. Last night at dinner and this morning, our World Bank representative spoke to the importance of the citizens of Africa being involved in their own decision-making, the planning, the execution of these programs. And what we've learned from like WHO and USAID and other sources is that they also, 80% of them in sub-Saharan Africa get their health care and health education from practitioners of traditional medicine. And this is an unspoken, unutilized, under-recognized group of health providers, true kind of frontline workers. You recently, the Gates Foundation funded up in Borno State traditional healers and religious leaders to try to address the immunization advocacy program. So my question to the team is, how do we utilize this group of true frontline workers who are in the communities, trusted, not going to take jobs at CDC? And the reason many people walk past the public health department is because they're walking to a traditional healer. How do we involve them in a meaningful way in the health of their countries?
Thank you. Let's hold for a moment and let's take 3 or 4. Yes, please.
Similar to her question, I'm Sarah from the Rollins School of Public Health at Emory. Similar to the question she asked, I was going to ask about the community health workers. I think for a long time have not been involved in decision-making in the policy process. How can we get them appreciated and more involved? Because as she said, they are in the front line. And I recognize right now in Ethiopia, I was just talking to somebody, there is a lot of progress that has been made with investing more in community health workers, where they have one community health workers to 5,000 people to facilitate simple things as birthing with mothers, vaccine and immunization coverage. I feel like that's something that's not being talked about a lot more, and they really need to be pulled into not only working on the ground, but even in the policy process. We need to hear more from them.
Thank you. Yes, please.
I have a couple questions, so I can let...
What's your name?
My name is Omenka Uchendo. I'm a law student at Georgia State, so you can go ahead, because I have a couple. Oh, okay, okay. Well, I first wanted to highlight Deborah Work's comment about talking to Africans about solutions to problems. I'm a Nigerian, and I'm also an American citizen, born in Nigeria, raised all over the place, and I've been raised mostly in America too. So it is very, very important for everyone in this room, everyone interested in global health in Africa, or just interested in humanitarian work in general, to remember that we are talking about partnership with the people in these countries. And even as a Nigerian American, I have to remind myself of that. I can't take my own Western upbringing and try to force it down my own citizens overseas. So I really appreciate that comment, and I wanted to highlight it. And then I had a question for Dana, and you mentioned that, or I think, no, Mr. Bremen. Sorry, you mentioned that the Bill and Melinda Gates Foundation is only able to implement some innovations in one country at a time, or with one provider at a time. I just want to know if you could expound on that and maybe talk more about why.
Okay, thank you. Are you done?
No, I had one more question.
Oh, okay.
my last question for everyone, especially Ms. Deborah Work, is I want to know, what are your thoughts about influencing governments to be more transparent with spending? I think, especially as a Nigerian, I don't like to bring this up because it puts my country in a bad light, but government corruption is a big elephant in the room. We're talking about trying to allocate funds to more health programs. How can we do this when, speaking of Boko Haram in Nigeria, Nigeria's defense budget, billions of dollars, not naira, dollars missing from the budget. I mean, that is crazy. Looking forward, trying to implement change, we really need to galvanize leaders to realize the immense importance of putting the money where it's supposed to go. So I'm curious to see what you all think about, as global health practitioners, how do we influence these type more political problems?
Thank you, Amanda. Yes, let's take one more and then we'll come back to our speakers, and please be patient. We'll have another round. Yes, sir.
Thank you. My name is Peter Dean. We were asked to be provocative, so I'm going to do my best. We've been told that resources and leadership are key, both individual and institutional. Most of the discussion today focuses naturally on what US-based institutions are doing and how locally based institutions can take over responsibility. You travel in Africa, one country that's obviously investing heavily in Africa for its own strategic reasons is China. You can travel around Nairobi, Kenya, and see that visibly. Is there cooperation with Chinese organizations in global health, especially in Africa? And what opportunities exist to promote that kind of cooperation?
Thank you.
Hey, maybe I could make two comments to start us off. First, on traditional healers, there's a lot that's being done, and it's important to understand the background of those healers. We've been working in a plague endemic area of Uganda for years to establish a plague research center and also interventions to eliminate plague there. There's an exciting opportunity, a new test that works like a pregnancy dipstick. 20 minutes and you can diagnose plague from sputum, urine, serum, or lymphaspirate. And to do this in the community, they reached out to the community healers who were quite concerned about plague. They don't want to get it, and they know that it doesn't respond to the treatments they have. So they taught them that if someone has fever and cough, to refer them to one of the places that can do this test and treat. And soon after doing this training, one of the traditional healers identified a farmer with cough and fever, referred him to the health center. The health center did this 20-minute dipstick, confirmed that he had pneumonic plague, entered him into a trial that's underway that will help all of us understand how best to treat plague, treated him with an antibiotic, and 3 days later the farmer was back at work. Without that system, we might have had a large outbreak. He might have died, his family and others might have died. I talked with that traditional healer when I was there. He would like more skills. He's using herbs, not based on traditional African experience, but actually based on a training he got 20 years ago from a German NGO that came in and told him what herbs to use for what different conditions. Every community has strengths, and one of the great challenges that we have is identifying those strengths and enlisting them to help promote health, and that includes help push for health, because activated communities will demand better resources, whether it's water and sanitation or roads or healthcare systems or education. That's going to be critically important. I think, as Dana said, one of the crucial and incredibly important roles of philanthropy is to take risks, is to try things and demonstrate what works so that governments can then take it on, communities can then take it on. And on China, I would just say we have a very productive relationship with China CDC, which was created or strengthened based on US CDC after SARS, and they would like to do more work globally. We've involved them in polio work in Pakistan, and we've involved them in a series of efforts to improve training around the world. So we think there are potentials to work together on the health arena. It's a bridge. Even if you go back to smallpox eradication, the US and the then Soviet Union worked together to advance smallpox eradication. And whatever is happening elsewhere in society, we have a very productive, constructive relationship with Chinese public health authorities. In fact, when H7N9 emerged, we were there with them. We had helped them learn how to sequence it, post it, work on it, control it, and they've been completely open ever since. We've been working shoulder to shoulder with them on it, and it's a great example of collaboration and trust building.
Thank you, Tom. Dana, can you talk a bit about, go back to the Nigeria case. How do you engage community health workers and elevate and motivate and empower them? And how do you circumnavigate a situation where there is an endemic corruption, but it doesn't necessarily forbid all opportunity to operate, but it's a matter of circumnavigating?
Thank you, Stephen. And those are great questions. Let me comment a bit on community health workers, but also the private sector and health-seeking behavior too, the private sector, traditional or non-traditional private sector providers. And there's some interesting research that's come out recently around OECD health systems that says that something which should be self-evident, that the OECD health systems, which are most effective, which have the best health outcomes, are in fact the most responsive to their citizens. And their health needs. Responsiveness equals efficiency and ultimately effectiveness. And this should be pretty self-evident, as I said. I mean, who wants to go to the DMV for your health care, for example? Who wants to go to a monopoly that's not very responsive? You want to have choice in terms of provider. And this is where I'll say something a bit provocative. In a room full of doctors, and me not being a doctor, that I've found that healthcare is often a bit top-down, a bit condescending, a bit patriarchal, and doesn't trust people's decisions enough. And people are voting with their feet in Africa, in Asia, here. And I think that health systems need to respect the votes of people as they choose their provider and try to strengthen the providers that they're choosing as much as one can and try to reorient them up the chain when those specific lower-level providers can't provide service. The issue of responsiveness in health systems, which are responsive to their citizenry, is also, I think, a major strength of community health workers, because community health workers are typically from their community, and therefore are more responsive to the needs of their brothers and sisters in their community. And so, in fact, the Gates Foundation and Bill and Melinda recently approved part of our strategy is to strengthen community health workers around the world. In terms of improving their performance management, improving the innovations that they can introduce and deliver. In Nigeria, they have a bunch of community health workers, but they, in fact, aren't community health workers. They're just health workers. They call them CHWs, community health workers, but they stay in facilities, which, as I said earlier, don't get any clients. And so we need to get these community health workers actually out into the communities doing their door-to-door work, which we think is so powerful. I just want to, I think the question might have been about what I had said, and I'm sorry I wasn't very clear about innovations, one country, one provider at a time. This isn't, I think, just a challenge for the Gates Foundation. This is a challenge for donors and ministries of health around the world. If you take, and I'll get the dates partially wrong, but if you take two innovations that came up, two life-saving interventions that came up, that were discovered and understood to work in around 2006 or 2007, which was male circumcision, Tom talked about earlier, and chlorhexidine for clean cord care. They both were launched in 2006 or 2007. Male circumcision, now the 20 million circumcisions that need to take place in sub-Saharan Africa, through persistence, through a lot of money, through training one provider at a time, we've now moved that up to about 6 million circumcisions having been done. Chlorhexidine, life-saving intervention. It's saved a few kids in Nepal. Just been recently introduced into northern Nigeria and Sokoto. Other than that, it's just dormant. And so that's the challenge in front of all of us. We know these things work, but getting them adopted and into health systems is, I think, a huge challenge.
Rob, we had community health workers, traditional health providers, corruption in China. These were the four issues that were put on the table. Would you have any comments you'd like to offer?
Traditional healers. The only example I can give you is at the beginning of the HIV epidemic in Africa. when we didn't have treatment, we didn't even have diagnosis. Most countries in Africa had a pact with traditional healers. On the negative side, the traditional healers would put all kinds of concoctions and give it to a patient and say he has been cured, which derailed a number of the only armament we had, which was health education. But once the National AIDS program started working with traditional healers, it was a fantastic change where you could explain to them, this is not something you can cure, but you can do all of these things to prevent the disease. And as most, probably 80% in most of the African countries who go to traditional healers, they contribute a tremendous amount in preventing this disease, in giving counseling, and in making patients comfortable. That's the positive side. On the negative side, I think as soon as we got the diagnosis and the treatment, we just dropped them like a hot cake. That is, on community health workers in Ethiopia, the first organization that put $1 billion on the table for AIDS in Africa was the World Bank. And at that time, Ethiopia, the two countries we took to the board for financing out of that $1 billion were Ethiopia and Kenya. Ethiopia had only 300 health workers. Now there are millions which have been funded by the Global Fund, by PEPFAR, and part of the reason why Ethiopia has reached MDG4, and it is one of the countries which is expected to reach MDG5, is because of these cadre millions of health workers that the country has developed. And it is something which should be applauded and something transferable to other countries as well. Again, I'm going to sound like a broken record. Funding is fashionable. So if somebody is funding, if the order of the day is circumcision, all the money is going into that, and you go to a country and say, I have money for circumcision. You drop health workers and you move into that. If it's health workers, you move into the other. That's what I mean by a mindset change. Corruption, transparency. About a year and a half ago, the Global Fund almost collapsed for a number of reasons, one of them being accused of the money being misused. There were a number of things. One, the money which was being misused, although a penny which has gone to HIV/AIDS, if it's lost, it is a loss. By any standards, the resources that were lost of the Global Fund were not much bigger or significant than other organizations. It just got into the media, it was publicized, and there were a number of reasons for it. One of them was the system in place. There was an inspector general who would go and say, we gave you money to buy a pen. If you don't show him the pen, the money is stolen. In many of the countries, Ethiopia being one of them, with the money given to them for AIDS, tuberculosis, and malaria, they put a lot of resources in training community health workers. Is that corruption? It's left to interpretation. Again, it goes back to ownership. It is stolen at country level, and people should be held accountable. No money which is coming for a specific purpose, especially for saving lives, should not be used for anything else. But accountability goes both ways. It has to be the people who are implementing the program who should be held accountable. It's also the donors who give the money who should have a robust monitoring and supervision mechanism in place. It's a long problem. I don't know where we are going. I remember when we did the multi-country program in Africa, I had a colleague who was a German colleague. When we went to country and people were complaining money is being lost, he said, this was being given for an NGO which was working with people living with HIV. He said, in the West, when we steal, we use a shovel. This is a teaspoonful. As long as they are doing something to save lives, let's move on to the next thing. It's a choice. I know very little about China, and I'm not an expert on China, but I'll tell you one thing, which a year ago, I was in Shanghai, and the development ministry, when giving us a talk, said, we are good for Africa because our knowledge of development is new. We know how to take Africa to the next level. The West had forgotten where it came from. So this is what we provide. I'm quoting, and that's up to interpretation, and we will see where China takes Africa.
Thank you. Bob,
Well, I mean, I just would say that, again, upstream from public health, but with huge impact on public health, you know, unlocking the potential of people that are living in desperate poverty is not just an ethical prerogative, but it's a societal and civilization-wide need. And the single most, or the most important reasons that are impeding that sort of movement towards addressing inequities is political will and empowerment, as has been said, of people locally, but also corruption. And so it is absolutely should be, even at a public health level, one of the most foremost issues to address, whether it be small, because small at the local level we're talking about has huge impact, it can derail programs, or whether it's huge, like the other examples that were given.
Thank you. On the China issue, frankly, over the years, there's been sort of minimal active cooperation other than the kind of things that Tom talked about, but their investment in malaria remains pretty profound and goes back decades. In the artemisinin, the combination artemisinin therapies are Chinese-based, and you see a lot of resistance accumulating now fairly rapidly to that in the Mekong, and that's a direct threat to all malaria programs potentially in Africa. And there's a pretty strong shared interest in cooperation, and I think you could imagine greater cooperation in that regard being driven by a shared interest among Africans, Southeast Asians, Chinese, and the United States on the malaria control agenda. We have a few more minutes, and we can take a few more quick interventions, and thank you for being so patient. Sir.
Alan Hinman, Task Force for Global Health. Tom, you appropriately talked about some of the great progress that's been made, and then also the unfinished as well as unaddressed agendas. And then Dana talked about the fact that foreign assistance is plateauing, and that countries in Africa are providing only 2% of GDP towards help. They need to be raised to 3%. This kind of argument and discussion has been going on for quite a while, and the 1993 World Development Report that showed how investing in health was good for development didn't seem to have changed many finance ministers' minds. As we realize that we need to maintain efforts in order to maintain the gains we've made, the 90% reduction in measles mortality in Africa in this decade alone, the past decade alone, is going to be totally reversed if we don't maintain the efforts. So the question is, how can we encourage countries, show them why it's important for them to go from 2% to 3%, given the fact that addressing the unaddressed agenda is going to require foreign assistance, as has been important in getting the progress we've made so far. How can we get countries to invest more in health?
Thank you. Yes, please.
Hi, my name is Marjay Etheridge, and I'm a film producer with Sustain Atlanta and Field of Hearts Entertainment. My question is, have you ever thought about the power of media as it relates to solving these kinds of problems, not underestimating the impact of a great story and using those stories, success stories, to inspire change in those communities? Thank you.
Thank you.
Morning, I'm Beth Miller, and I've worked for many years on tuberculosis and AIDS at the Centers for Disease Control and implementing the PEPFAR program in Africa. And actually following on Dr. Hinman and a number of other comments on corruption and governance and the need to talk to Africa. I'd be interested in, particularly from Dana and Deborah Work, in examples of how to get finance ministers at the table. In my experience in tuberculosis in the year 2000, I know Dr. Helene Gale was there. We had a ministerial level meeting, Africa and Asia and Europe, on how to address tuberculosis. And the key aspect of that meeting was getting the finance ministers at the table. So I think we often talk about ministers of health and peripheral health workers, but we need to talk where the money comes from. And I'd be interested in hopefully some positive examples you might have.
Thank you. Yes. Take these last two
Hi, Stephen.
comments, and then we'll come back and close.
Okay.
Thank you.
This is Claudius. My question is just to make a comment on Dr. Deborah Work. The other day said, let's stop talking Africa and talk with the Africans. One of the issues that I have is partnership. According to the world, the UNESCO, if Africa have lost many of her intellectual capacities. One example has been one Ethiopian, 75% of her intellectual capacity live in Western countries to better one life. One example could be the number of doctors in Chicago surpasses the number of doctors in Ethiopia. So if that being said, I mean, what kind of opportunity is there to galvanize the African diaspora abroad?
Thank you. And our final intervention. Thank you.
Hi, Kelly Stempert. I'm a freelance medical writer here in Atlanta. Spent a number of years at CDC. And my question is in particular for Dr. Frieden. What is the role of qualitative research in engaging the people of Africa, in particular the community health workers? Something like knowledge, attitudes, practices, baseline, to then show a difference after intervention.
Okay. Who'd like to jump in? Deborah?
Okay. The first one is, how do we get finance ministers at the table? There was a very bad term which was misused in the 90s. It's called conditionality. This was a term used by the IMF and the World Bank because it was used the wrong way, structural adjustment, etc. It got a bad name. I'm not using that interpretation of conditionality. Any funding that's going to a country, depending on the capacity of the country, should be conditional on the country itself putting its resources first. Why? So there is a thing called sustainability. Every individual who puts money in any country should think of, so what happens when I leave? So if we use this term in that way, then that is one way of bringing finance ministers onto the table. The Ministry of Health in many of the sub-Saharan African countries is the weakest ministry. It's ministers of finance, plan, and defense who call the shots in cabinet meetings. Again, a lesson from the HIV/AIDS movement. It was the reason why HIV was pitched as a development issue and a national issue was to get these entities on the table. If you convince a finance minister of a country, you will get resources for whatever you want to do. So that's one way of getting them on the table. We have a very good example, and I'm going to be very partial.
Yes. I'm going to have to go. So if I can say a couple of things, then you finish, because otherwise I'll be in trouble. But I just wanted to make 4 very brief points. First is to convince finance, talk finance. We've got a great return on investment. We need to document that better and disseminate that information better. I'm sorry, Deborah. No. Second is, despite that, never forget that our strongest argument is health. Ultimately, it's better to be alive and healthy than sick and dead. And that's the strongest argument we've had. But that also means having good documentation of outcomes, real outcomes that are accurate, convincing, and can convey what's happening with health. Third, activating communities to pressure for the services that are needed is going to be very important, because any government will respond to pressure, and that's very important. And fourth, I remember I asked Senator Inouye when he was still alive and chair of appropriations, how can we get more money for global health? And he told me something I will never forget. He said, don't tell us the good things that will happen if we give you the money. Tell us the bad things that will happen to us if we don't give you the money. With that, I have to step off, but thank you very much.
No problem. Thank you, Tom. I'm going to just ask Rob and Dana and Deborah just to give a quick closing comment, and then we're going to adjourn and move to the next panel. Rob?
Let me,
Deborah, do you want to
Steve,
finish?
let me finish what I
Yep.
wanted to say. I was going to give the example of a minister of finance who has made a difference. It may be early days. This is the minister of finance of Nigeria. For the first time, she front-loaded the health budget of Nigeria. Why? Because she could see what would happen if that's not done. So it's a good example. I need to respond to the erosion of the intellectual power in Africa, and who am I to talk? I'm not in Africa. I haven't been working in Africa for a very long time. But the issue which nobody wants to touch is it's not economics. It's not because people want more money and a better life only that they live. It is because of governance issues that we don't touch. That is what is driving the intellectual power of Africa to a place where there is freedom of speech. The lady who asked about how do we use media, well, in many of these countries, there isn't free press. So that's how I want to end.
Thank you. Dana?
Yeah, just a couple quick comments. That I have a theory, and perhaps others share it. That Deborah, as Deborah Work said, that finance ministers want to invest in things which are good for their country, and they don't see their ministries of health as all that effective and efficient. I'm a big believer in what the World Bank is really pushing around results-based financing. I think if you can deliver results, then you're likely to get investment. We're working with a couple of countries in Africa right now to position those countries so that when extractive industries start to really generate money in about 7 or 8 years in places like Tanzania, they're actually putting some money aside for the social sector, for education and health. So getting ahead of some of these revenue-generating things. Once the money's flowing, it's really hard to set aside some money for education and health. So getting ahead of the deal. The power of media, of the 1,200 Bill and Melinda Gates Foundation staff around the world, about a quarter work in communications and advocacy. We really believe in media. We really believe in the power of influencing, which is, in fact, we think much more powerful than the actual money that one might spend, the soft power I talked about earlier. Just the last thing I want to say is that I hope during the day somebody will mention, in addition to me mentioning it right now, that probably the greatest investment in health that one can make is in girls' education. Girls educated are healthier, and their children are healthier.
You have the last word, Rob.
The last word, a great position to be in. So I guess listening to everything today, what's clear, there's sort of a butterfly effect in that what happens in Africa or what happens in the United States or Europe affects people all around the world. And what is clear, what we've observed, but more has to happen, is that the center of gravity for how how problems are recognized and how decisions are addressed is making a radical shift, for instance, to local. So in Africa, this is happening. It needs to happen more to get where we need to go, but it really is a sea change over the last decade. And I just would close by saying that I think our chances, we have big problems globally in the 21st century. We really haven't talked about them in any detail here, but I really think our chances as a civilization to successfully address those challenges ahead depend on encouraging sparks of genius and motivation and brilliance and dedication wherever they may appear. And there's a very good chance that they may appear in Africa.
Thank you on that note. Thank you all. Please join me in thanking Reeves.